Good morning, everyone. Myself, Dr. Pranita Sahai. I'm working as a senior resident in the Cornea unit at Dr. RP Center for Ophthalmic Sciences, and I'll be presenting on my research in microbial keratitis following accelerated corneal collagen cross-linking in keratoconus patients. So as we all know that CXL is the gold standard treatment for halting progression of keratoconus. However, it is associated with certain complications like corneal haze, sterile infiltrate, progression of keratoconus, and the most dreaded one, microbial keratitis. So the aim of the study was to assess the pattern of microbial keratitis following accelerated corneal collagen cross-linking in keratoconus patients. This was a retrospective study conducted at Dr. RP Center for Ophthalmic Sciences, AIIMS, New Delhi, in which all cases that underwent accelerated CXL between June 2014 and May 2018 for progressive keratoconus were studied. A total of 657 procedures were performed, of which 514 were isoosmolar and 143 were hypoosmolar. The standard treatment was done for all the patients. It was done either under topical anesthesia or general anesthesia based on the age of the patient. Epithelium was debrided with the help of 20% ethyl alcohol in the central 8 mm zone. Riboflavin was applied every 2 minutes for 20 minutes, following with a UV exposure of 18 milliwatt per centimeter square for 5 minutes with riboflavin application every 30 seconds, and a bandage contact lens was applied at the end of the procedure. The patients were prescribed moxifloxacin and carboxymethyl cellulose on follow-up, and the patients were followed up on day 1, day 4, 1 week, 1 month, 3 month, and 6 month. Topical steroids were added only after the BCL was removed and complete epithelial healing was documented. With any suspicion of infection, the BCL was removed and sent for culture sensitivity. Corneal scraping was performed and the specimen was evaluated with microscopic examination and culture sensitivity. Confocal microscopy was also performed for the cases. Coming to the results, we had a total of 7 cases of microbial keratitis developing post-accelerated corneal collagen cross-linking. The median age of the patients was 11 years, and the male to female ratio was 5:2. The median time to presentation following intervention was 3 days, and the presenting visual acuity varied from 618 to finger counting close to face, with 4 patients presenting with a visual acuity less than 660. An association with vernal keratoconjunctivitis was seen in 57% of our cases. The ulcers were central in 86% of the cases, and the size varied from 2 into 2 mm to 4.5 to 5 mm, the infiltrate size varying from 2 into 2 mm to 6 into 7 mm. The microbiological results suggested that the BCL culture was positive in 42.8% of the cases, and Staph aureus being the most common organism seen in 42.8% of the cases, coagulase negative staphylococcus in 14.2%, alternaria in 14.2%, and polymicrobial keratitis was seen in 3 cases, attributing to 42.8% of all the cases. The combination of infections was staphylococcal and aspergillus, staphylococcus and mucor, staphylococcus and acanthamoeba. The antibiotic sensitivity pattern suggested that 83.3% of the cases were resistant to moxifloxacin and gadifloxacin and were sensitive to broad-spectrum antibiotics tetracycline, chloramphenicol, and also sensitive to cefazolin and tobramycin. This is the outcome of all the 7 patients. Most of the patients responded to medical therapy and healed with a corneal opacity and were rehabilitated with contact lens. However, one case developed a diffuse large corneal opacity with a cataract for which an optical triple procedure was required. Case 6 had an aggressive course, was positive for alternaria species, did not respond to maximal medical therapy, and perforated on day 5, for which a therapeutic penetrating keratoplasty was required. This is the 1-month follow-up photograph showing a large clear graft with multiple loose sutures. Review of literature suggested that there are total 17 cases of post-CXL keratitis reported as of now, of which most of them are isolated case report. Only 1 case series exists, reported by Shetty et al. From India itself, of which there are 4 cases developed post-CXL infections. CXL was conventional in this study, and all cases were resistant to moxifloxacin, and all the cases responded to medical therapy in this case series. So this is the first case series of microbial keratitis after accelerated corneal collagen cross-linking. So certain differences which we noted in our study compared to what has been reported previously in literature, that is our patients were younger compared to what has been reported earlier. The mean age was 12.3 years compared to previously reported cases being 24.2 years. This can be because of the high incidence of pediatric keratoconus with VKC in our region. A high incidence of post-accelerated CXL microbial keratitis was noted, which is 1.1% in our study, compared to that reported by Shetty et al., which was 0.0017%. This can be because of the younger patient having poor compliance to treatment, association with VKC, on and off use of steroid in these patients leading to a compromised ocular surface and altered natural ocular microbial flora, and poor hygienic conditions maybe in our country. Polymicrobial infections were seen in 43% of our cases. However, in previous reported cases, there has been only one case report of polymicrobial infection. This can again be because of the association of VKC, large epithelial defect, BCL application, multiple risk factors for infection in these patients. Then a high rate of drug resistance to fourth-generation fluoroquinolone, as has been previously reported in literature. The hypothesis for this can be the rampant and irrational use of topical antibiotics in our country, and the high-power UV radiation and accelerated corneal collagen cross-linking can also be mutagenic to the commensal microorganisms. So to conclude, Staph aureus is the most common microorganism seen in these patients, and a combination of concentrated cephalosporin and tobramycin would be the best option in treating post-CXL microbial keratitis in view of high resistance to the fourth-generation fluoroquinolone noted in these cases. In the end, I would like to thank all my mentors back at RP Center AIMS for helping me conduct this study. Thank you.